Surgical management of the large intestine is driven by a precise algorithm. To make the right decisions in the operating room, you have to understand how three distinct biological systems intersect: embryological blood supply, molecular genetics, and intraluminal pressure dynamics. You need to master a specific set of clinical scenarios. We are going to map the timeline of the adenoma-carcinoma sequence, define the exact anatomical boundaries for elective oncological resections, and evaluate the protocols for emergency damage control. Memorizing isolated anatomical facts is not enough. You have to synthesize these constraints to select the correct node on the clinical decision tree, whether you are planning a prophylactic surgery or managing an acute perforation. The primary function of the colon is to absorb water and sodium. Every 24 hours, about 1,000 milliliters of fluid enters the cecum from the ileum, and active transport systems reduce that volume to just 200 milliliters of excreted feces. At the same time, the normal colonic microflora ferment dietary fiber into short-chain fatty acids, providing essential metabolic fuel for the mucosa itself. Macroscopically, you distinguish the large intestine from the small bowel by three distinct structural features: the tinea coli, which are three longitudinal muscle bands, fat-filled peritoneal tags known as appendices epiploicae, and haustrations, the saculations created by the tension of the tinea coli. Look at the vascular map. The midgut receives its blood supply from the superior mesenteric artery, or SMA. This vessel feeds the right side of the colon, extending all the way from the cecum to the distal transverse colon. The hindgut, covering the remainder of the distal colon, is supplied by the inferior mesenteric artery, or IMA. These two distinct embryological territories meet near the splenic flexure. Peripheral branches from both the SMA and IMA typically anastomose to form a continuous vascular supply known as the marginal artery of Drummond. But blood flow in the watershed area of the splenic flexure, right at the junction of the midgut and hindgut, can be highly tenuous. Because of this precise anatomical vulnerability, a sudden occlusion of the IMA predictably leaves the splenic flexure poorly perfused, leading directly to ischemic colitis. Most colorectal cancers develop from benign adenomatous polyps. The risk of malignancy depends heavily on histology and size. Tubular adenomas carry the lowest risk, while polyps with predominantly villous features are far more dangerous. As the size of the adenoma increases past 3 centimeters, the probability of invasive malignancy rises sharply. This histological section shows a pedunculated polyp. You can see normal colonic mucosa at the base, contrasting directly with the pre-malignant tubulo-villous changes actively forming at the apex. This timeline accelerates dramatically in patients with familial adenomatous polyposis, or FAP. FAP is an autosomal dominant condition caused by mutations in the APC gene, located on the long arm of chromosome 5. An APC gene mutation creates an extreme clinical phenotype. Colonoscopy reveals hundreds of adenomas coating the mucosal wall, well over the diagnostic threshold. Without intervention, a patient with FAP has a 100% lifetime risk of developing colorectal cancer. To prevent this, the standard surgical management is a prophylactic restorative proctocolectomy, removing the entire colon and rectum before the carcinomas have a chance to form. Lynch syndrome presents a different genetic failure. Rather than the APC gene, it is driven by mutations in DNA mismatch repair genes. Without these functional repair proteins, sporadic mutations accumulate, creating repeat sequences of DNA known as microsatellite instability. Because Lynch syndrome forces a highly accelerated progression from adenoma to cancer, often on the right side of the colon, the surgical algorithm requires an extended colectomy. Furthermore, the genetic profile necessitates rigorous surveillance of other organs, particularly the endometrium and ovaries. By identifying these specific molecular failures, surgeons can accurately predict disease progression. The genetic data dictates exactly when to intervene, removing the tissue prophylactically before the adenoma-carcinoma sequence reaches its endpoint. Once an invasive adenoma-carcinoma has developed, geography determines the presentation. Right-sided tumors typically cause occult bleeding and iron deficiency anemia. Look at this endoscopic view of a left-sided lesion. The massive, ulcerated tumor narrows the lumen, proving why descending colon cancers present with mechanical obstruction. Preoperative staging evaluates the primary site and checks for metastatic spread. Here we see a CT scan of the abdomen paired with a 3D formatted virtual colonoscopy. This technique accurately highlights a sequel tumor without the need for an invasive physical scope. This CT scan of the liver reveals multiple dark metastatic lesions. Because the venous drainage of the colon flows directly into the portal system, the liver is the first and most common site of metastatic disease. To achieve an oncological cure, surgeons execute a complete mesocolic excision. Because lymphatic drainage strictly follows the arterial supply, removing the tumor alone is inadequate. You must resect the entire lymphovascular basin supplying that segment of the bowel. For a right hemicolectomy, the dissection plane isolates the right colon and its mesentery. The critical maneuver is a high tie, flush ligation of the ileocolic and right colic arteries, directly at their origin from the superior mesenteric artery. A left hemicolectomy targets descending colon and sigmoid cancers. Here, the surgeon mobilizes the left half of the colon and performs a high tie ligation of the inferior mesenteric artery close to its aortic origin, along with the inferior mesenteric vein. Elective oncological surgery requires precise anatomical deduction. You are executing a geometric excision of the exact embryological territory and vascular supply that spawned the cancer. Acute mechanical failures require a completely different approach. Diverticular disease presents as acquired mucosal herniations. These occur predominantly in the narrow sigmoid colon, driven outward by high intraluminal pressure. Severe infections can also precipitate surgical emergencies. Clostridium difficile colitis can rapidly progress to toxic dilatation, destroying the integrity of the bowel wall and necessitating an emergency subtotal colectomy to halt systemic sepsis. When assessing complicated, perforated diverticulitis, surgeons rely on the Hinchey classification. This system grades the extent of abscess formation and peritonitis, providing a direct metric to decide when surgical intervention is required. In the event of a free perforation causing generalized peritonitis, the priority shifts strictly to damage control. Look at these two approaches. On the left, a Hartmann's procedure removes the diseased sigmoid colon, leaves the rectal stump closed, and routes the proximal colon out to the abdominal wall as an end colostomy. An end colostomy, like a Hartmann's, is often a permanent termination of the bowel tract. On the right, a loop colostomy maintains the continuity of the distal tract. It is typically a temporary measure, designed simply to divert the flow of feces and protect a fragile surgical anastomosis downstream. This radiograph displays an expanding metal stent positioned across an obstructing left-sided lesion. When endoscopic and radiological facilities allow, this stent decompresses the obstructive bowel, safely converting a high-risk emergency surgery into a semi-elective resection. In cases of severe contamination or cardiovascular instability, surgeons must abandon primary anastomosis and prioritize life-saving mechanical diversion to stabilize the patient. The large intestine operates as an interconnected system, strictly governed by the rigid laws of intraluminal flow, arterial pressure, and underlying genetic coding. A patient's molecular data, specifically mutations in the APC or mismatch repair genes, dictates exactly when a surgeon must intervene, establishing the critical window for prophylactic resection. The physical scaffold, the distribution of the superior and inferior mesenteric arteries and their parallel lymphatic basins, dictates exactly where the surgical margins must be cut to achieve an oncological cure. Whether you are executing a complex restorative proctocolectomy for FAP, or making the critical decision to perform a damage control Hartmann's procedure in the middle of the night, your success relies entirely on mastering these underlying physiological and anatomical rules.